Good morning, and thank you for joining me. My name is Christian Lane Krebs, and I'm a medical student based in regional Australia. I am also proud to be a person living with disability. The research I'm presenting today was undertaken by both myself and co-author Dr. Katrina Lane Krebs. Today, I'll be sharing reflections on a critical yet often invisible challenge: the transition from paediatric to adult healthcare for young people with disabilities living in regional and rural Australia. This is more than just a policy failure or gap in clinical coordination. It is a deeply human story of being cut adrift. For the young person and their family, the disconnection is loud, raw, and disorientating. To those outside, it goes largely unnoticed, silenced by the systems that have already seemingly moved them on. At each level, young people living with disabilities face unique barriers, not just in reaching care, but in being recognised, supported, and guided through one of the most complex transitions from paediatric to adult care. So why is it necessary to be understood? Well, understanding is the foundation of meaningful engagement, allowing individuals to move beyond surface-level knowledge to grasp the deeper significance of concepts, experiences, and interactions. In health, education, and social contexts, understanding enables empathy and responsiveness, fostering trust and the capacity to meet diverse needs authentically. Without understanding, actions risk becoming mechanical or misaligned from those they are trying to help. Whereas through operating from a foundation built in knowledge, decisions are more ethical, informed, and conducive to long-term positive outcomes. So how did we gain the information? Logically, we did it by speaking to families and young people, but let me tell you, it was so much more than this. We abandoned the sterile settings of formal interviews to foster a more relaxed environment, free from external pressures and the stigma of being, quote, on the right side. Informal conversations in natural social settings have proven to allow participants to share experiences in their own words, free from the constraints of formal interviews. In such settings, youth often feel safer and more spontaneous, allowing for richer narratives of transition, difficulty, resilience, and identity. This approach increases insights, developing relational, emotional, and structural dimensions of lived experience that might be hidden in a more rigid research format. The system isn't ready, and neither are they. Abrupt, isn't it? This graphic may be daunting to the eye, but imagine this image being more than just words. This graphic represents the emotional landscape young people face when navigating the abrupt shift to adult care. So although to you it is a knowledge tool that is a lot to take in, yes, but to the abundance of regional people living with a disability currently transitioning from pediatric to adult care, this image is their life. It is every doctor's appointment, every waiting room, and every follow-up email. It is all around them. Young people voice systemic barriers such as the withdrawal of services and the exclusion of their parents as the basis for their emotional burden. These are the feelings of fear, doubt, anxiety, and isolation that they just can't seem to escape. Consultations with young people and their families emphasize the internalization of the burden of transition. Now, these aren't just words. They are not just an act of academic discovery. They are indicators of distress, confusion, and vulnerability. And with systemic gaps comes human cost. Fear, anxiety, and uncertainty currently dominate the narrative of transition. These stories are deeply personal. However, they also sit within a broader structural challenge. So why does this matter beyond the individual? Well, rurality intensifies inequity. There are fewer specialists, longer travel distances, and patchy service provision. The system often addresses funding or compliance, but not the lived experiences. These systemic shortfalls translate into long-term costs, not just for the young people, but for their families, communities, and the healthcare system overall. Who falls through the cracks? The young, disabled, and disconnected. It commences with the 15 to 18-year-olds, many still in high school, just starting at TAFE for uni, or entering the workforce. For those without a disability, times are turbulent enough. Adolescents and adults are already navigating profound biological, psychological, and social changes. For those living with disability, the expectation to assume additional health-related decisions creates an unsustainable cognitive and emotional load. They're managing a physical disability, often with long-standing ties to paediatric teams. Until now, these supports navigated a convoluted pathway side by side. But at the stroke of a pen on their 16th birthday, those supports vanish. Suddenly, they are having to remember appointment times, new people's names, travel forms, and so much more. All the while juggling appointments with their normal daily life. One youth summarized, "It's like falling off a cliff. One day I had help, the next it was just me." Between the ages of 15 and 18, young people are thrown into one of life's most turbulent transitions. A phase marked by physical transformation, emotional volatility, now the relentless pressure of age requirements for services, insisting those with disabilities grow up and begin to adult before they are ready. Identity is still forming, yet expectations to self-manage, self-regulate, and make adult decisions come thick and fast. This period is often characterized by a collision of competing demands and a fragile sense of control. This burden compounds with developmental upheaval, where identity formation, peer relationships, and educational transitions already stretch adaptive capacity. These years are not just developmental stages, they are developmental under pressure. This pressure becomes more acute, with limited scaffolding to support autonomy, resilience, or health literacy. Yes, it's a time of becoming, but too often it is also a time of being overwhelmed by responsibility. Overwhelming often results in shutdown and disengagement. These young people often have limited capacity to function within the adult system, such as scheduling appointments, managing scripts, navigating reviews, or even speaking confidently with a GP. Working with the families over many years, the chronic perplexity and nuances of systems such as the NDIS are complicated enough. Imposing a direction to manage complex system navigation and premature self-management at this stage risks disengagement, diminished confidence, and compromised long-term health outcomes. So where are the youths exactly? Let's talk about geospecifics. Non-metropolitan, regional, or rural does not simply mean that it is not a capital city. Contrary to popular belief, these words are not synonyms for slightly on the outskirts of a metropolitan area but still has access to all the healthcare. No. Using the modified Monash model, we're talking about MM2 areas or regional centres like Rockhampton, MM4 or medium rural towns like Monto, MM6 or remote communities like Winton, or MM7 or very remote communities like Birdsville. But why does this matter? Each level brings increasing complexity in service access, health workforce shortages, and social disconnection. This isn't just a map, but it is a framework for understanding how geography can quietly magnify vulnerability, adding to the burden of aging out of a scope of familiar healthcare systems. Marginalised youth in regional and rural areas already experience reduced access to health, education, and social supports due to geographic isolation, systemic under-resourcing, and workforce challenges. This lack of scaffolding compounds with existing inequities, leaving young people with disability especially vulnerable during critical developmental and transitional stages of life. The recurring theme is clear: a state of being or living with a disability compounded by location, where services are fewer, further away, and not designed for gradual or supported transitions. Once again showing the system isn't ready, and neither are they. The transition process is riddled with systemic barriers. Firstly, there is no structured transition infrastructure in place in regional and remote contexts. It's largely ad hoc or as they go. Secondly, paediatric services tend to stop abruptly at 16 or 18, depending on the service. There is no soft landing, no overlap, and no warm handover. Paediatric patients that have transitioned to adult care are simply left to fend for themselves, and unless they've been taking notes since the age of 14, they are often building their knowledge of the healthcare system for the first time. And I'm sure many people can relate that it is not a simple system to learn. Thirdly, parental advocacy. Once central in paediatric care is often excluded once the patient becomes a legal adult, leaving young people feeling isolated and overwhelmed. What we see is a perfect storm. There is developmental immaturity, systemic opacity, geographic isolation, and a loss of support. These factors create a dangerous gap where continuity of care is disrupted and the risk of disengagement skyrockets, leaving people with a disability as a product of their environment, unsure where to go or how to start. Snowballing from a disengagement from one service to a total dysregulation of their medical conditions, resulting in an increase in chronic pain and placing the abundance of youth at disproportionately high rates of sedentary lifestyle and secondary health complications, all because there was not enough time taken to show them how the system works. Building bridges, not barriers. Yes, there are opportunities and solutions. There are many tools like the Transition Readiness Assessment Questionnaire or TRAC, which assesses skills like managing medications, understanding health conditions, and communicating with providers. But they're underused, especially outside of metropolitan areas like Brisbane and Sydney, still leaving rural patients to fend for themselves and navigate this transitional period alone. TRAC also does not achieve the transition. They only signify the readiness of a paediatric patient to continue onto adult care. Reducing a lived experience to a tool or form-based evaluation risks stripping away the depth, nuance, and humanity embedded in a personal narrative. Genuine understanding requires approaches that honor context and emotion, recognizing that tick box measures alone cannot capture the complexity of individual reality. Qualitative narrative assessments recognize the meaningful evaluation requires time and space to explore individual differences, allowing the richness of a personal story to illuminate experiences that standardized measures overlook. We've seen firsthand how participants struggle to coordinate fragmented healthcare. Enter a new role. This new role isn't about adding more red tape and leading to greater confusion amongst the transition of pediatric to adult care. It's about embedding clinically educated, system-literate nurses who understand disability from the ground up. An advanced practice nurse, a disability specialist. This role would be a primary care, community-based advanced practice nurse, best positioned to facilitate transition and continuity, guiding young people through the adult system, building readiness, and providing relational continuity between fragmented services. Developing mentors, youth design programs, and digital resources that reach marginalized communities. Solutions must be rural-proof and co-designed with geographic equity in mind, rather than simply adapted from urban models. They must be sustainably funded to become an ongoing regional or rural resource. We must look beyond traditional models designed for chronic disease management. While advanced practice nurses have long played a key role in supporting patients with diabetes, cardiac or respiratory conditions, disability requires a fundamentally different approach. One that recognizes the socio-relational development and lifelong nature of disability rather than framing it through a disease lens. The APN disability are transition and continuity of care facilitators for people with disability. This role includes advocacy, coordination of multidisciplinary care, transition planning from adolescence through young adulthood and beyond. Disability impacts on each stage of life differently. APNs would liaise with families, schools, higher education, accessibility teams, job training providers, and community services, components that are often absent in adult-oriented systems. In rural and regional areas where allied health services are limited, this role would be a transformative aspect in ensuring continuity of care and reducing vulnerability at a critical life stage. Overseeing NDIS funding to optimize outcomes is an essential component of reform. This role must have a community focus and be accessible within communities outside of metropolitan areas. Disability intersects with education, housing, employment, identity, and intergenerational trauma in ways that defy biomedical categorization. It requires practitioners who can lead with lived experience insight, trauma-informed practice, and deep knowledge of rights-based frameworks. Not a sub-role, but a specialization in its own right. This emerging model of advanced practice brings together clinical expertise, cultural humility, policy fluency, and long-term relational care. It represents a deliberate shift away from the transitional biomedical framing of disability, embracing instead a biopsychosocial model that is grounded in person-centered care. Situated at the primary care interface, this role recognizes disability as a dynamic, contextually embedded, and community-informed experience, one that warrants the same strategic workforce investment and professional recognition as cardiology, oncology, or diabetes. Here is a challenge and opportunity. One young adult described their transition as the moment I stopped being me and life became one huge problem. That's not just a failure of care, it's a failure of compassion. We have the tools, the knowledge, and the capacity to do better, but we must make the start. If we don't act now, the lives of young people living with disability in rural and regional areas will continue to be put on the back burner. We must take action to ensure someone advocates for those who cannot. The barriers are clear, the effect is huge, and only we have the ability to make the change for better. The call to action is simple. Listen, adapt, empower. Listen to what regional and rural people are telling us. Adapt our models to the realities of regional and rural life, and empower these young people not only to survive the system, but to own their health journey with confidence and dignity throughout the lifespan. Australia has made significant advances in health reform and disability inclusion. Yet, there is no formally recognised advanced nursing role focused on disability. This gap leaves many, especially those living in rural and remote communities, navigating fragmented care systems with little support. The proposal is the creation of an advanced practice nurse disability specialist, a role that combines clinical skill with deep knowledge of the NDIS, cultural humility, and long-term relational care. It's not a sub-role of chronic disease, but a unique, necessary specialization that moves us from a biomedical to a biopsychosocial model of care. We've done it for oncology, cardiology, and diabetes. It's time we invest in workforce expertise for Australians living with disability and begin championing the needs of people living with disability in regional, rural, and remote areas, both in primary care and in the community. We must transform the fragmented transition periods into futures of strength, dignity, and lifelong support. Let's start building the future. Our regional and rural communities demand an advanced practice nurse disability specialist now, because all people with disability deserve more than survival. They deserve power, presence, and continuity.